Welcome, everyone. Dr. Jack Wolfson here, cardiologist and founder of Natural Heart Doctor, with my friend and colleague at Natural Heart Doctor, Dr. Andrew Rudin, and we're going to talk about think before you stent. And welcome, Dr. Rudin, to this conversation.
Yeah, thanks. Thanks for having me, Jack. Pleasure to be a Natural Heart Doctor talking about this important topic.
All right, very cool. So it's kind of like think before you stent. Um, this is really important because there's hundreds of thousands of stents that are being placed every year in the United States alone. And I think the culmination of what you and I are going to talk about is that so many of those are unnecessary. And not only are they unnecessary, but I think we're causing more harm than good in a lot of people. And we just want to open up people's eyes to this topic. So should they get into the situation where they are being offered a stent or they're about to face a procedure, so that that they get some knowledge on this.
Yeah, no, it's an important topic, and I think your case study that you chose is going to illustrate some of the disconnect between what patients think and what the science shows.
All right, so to your point, here's what was just recently posted on social media by a cardiologist who would say that he's integrative, that he's holistic, that he is natural. But let's just kind of read this off here. Another heart attack prevented. A lady bought this book, read it, insisted that her GP order a calcium CT scan despite no symptoms. Results sky high. So the person had sky high coronary artery, very high levels of coronary artery calcification, saw this particular cardiologist. Stress test, the cardiologist says, was awful, despite a great lifestyle. Now a stent in a 95% narrowing, close call. So, Dr. Rudin, my friend Andy.
Yeah.
Another heart attack prevented. Did this guy prevent a heart attack?
No, he did not. But let me just go to this case because it's a great illustration of what happens every day in America. And that is, this patient would never even have qualified for a trial, would never qualify for the studies we're going to show, later in this talk, because this patient didn't even have angina. They were asymptomatic. So nobody in a medical literature, nobody in a university that's doing research would even put this patient in trial, because we know now for 40 years since we've been doing stents that this patient doesn't benefit from an invasive approach, doesn't benefit from angioplasty. They have no symptoms. So what are we trying to accomplish with the stent? Certainly not prevent an MI, as we'll show soon.
Well, but I'll play devil's advocate. Like, what are you talking about? The person had a 95% blockage, and you're telling me that fixing a 95% blockage, like, that sounds really scary. So you're saying fixing a 95% blockage doesn't prevent heart attack or save lives?
It's a good point, Jack, and it's not intuitive. So until you do the studies, until you really understand atherosclerosis, you may be confused by that, because a lot of times what happens is the doc shows a picture of the blockage and then the stent, and it went from closed to open, and everybody's happy. The family thinks the doc's a hero. The doc's grandmother thinks that he or she's a hero, and everybody's happy. But the truth of what happens in atherosclerosis is it's not just that blockage, that 95% blockage that we saw, that plaque is already ruptured. That plaque already it's finished with its inflammation. Its macrophages and foam cells have already eaten the cholesterol inside. There's really low inflammation in there, low heat, and it's coated over, Jack, by a very thick scab. So it's protected. That's not the lesions that gives us a heart attack, as you know. There was really good studies on this decades ago that showed that the vast majority of heart attacks don't come from the plaques that are already stable, like the plaque we see in this patient. They come from 30% blockages, 50% blockages, or even less. Atherosclerosis is a systemic process. If you have a blockage in your right coronary artery, or LAD, you have it everywhere. You have it in your carotids, you have it in your legs, you have in your kidney arteries. It's a systemic process that is driven by inflammation and oxidative stress.
So just to kind of summarize what you said is that heart attacks are not from a 95% narrowing. Heart attacks,
Yep.
as you said, are for the, the 20, 30, 40% narrowing that has a thinner cap that is more likely to be unstable, easy to erode or fracture, leading to acute thrombosis, clot that happens there. And you said that the 95%er is actually very stable. It's very rock hard, if you will. It's this rock hard chunk of calcium, really.
Yeah.
That's there, and it's
With
very
a thick,
stable.
with a thick scar and very little enzymatic activity. The stuff inside of a stable 95% blackjack is not inflammatory cells. It's if it's exposed to the blood, which it won't be because it's very protected from the bloodstream, it won't cause clot. It won't cause platelets to aggravate and a blood clot to form on top of the ruptured plaque. It ruptured, months ago, years ago, who knows when, and it's already now in a stable stage.
Very good. So and we're going to talk about the individual studies. So we're going to back up what we say, which is really so eloquently done in so many areas of medicine, right? There is no data. And what you and I are talking about, there's tremendous data. And why this cardiologist, and frankly, thousands of other cardiologists around the United States and around the world, why they think that they saved anyone's life, it really is a mystery on how these people have this, bravado, as you mentioned earlier, that that they're really helping people. It's really it's really scary. But and we'll summarize the studies here. But right, what happens is you take this 95% stable blockage, and now you've made it unstable, right? You've damaged the area. And now the person is on anticoagulants, blood thinners, for a while, other pharmaceuticals, and you've put this person at tremendous risk.
Yeah, you did a few things, Jack. One, you made the person a patient, whereas they may have known that they're at risk for coronary disease. Now they're a heart patient. They have regular cardiology visits. They're on multiple pharmaceuticals, which have risks. They have a lot of risk during the procedure, which I'm sure we'll talk about in a moment. But one other thing I'd like to say is, I think this cardiologist is in the minority. I mean, we have some data published online, I think from Cleveland, that showed that when they interviewed patients at cath, that almost 90%, about 88% of patients felt that cath was going to lead towards lower chance of them having an MI and lower chance of them dying in the next year. Whereas the referring cardiologist and the cardiologist doing the cath, the overwhelming majority of those doctors surveyed, correctly knew that the cath didn't have an impact on survival and didn't prevent MI because they knew the data.
So
they were doing the cath for some nebulous reasons that, patient specific or whatnot, but they knew the data, the vast majority of docs. This doc, at least in this quote, I think is discongruent with the data.
And that's why you and I practice a natural heart doctor, just because it's just, seeing these people get instrumented the wrong way. It's really frustrating. And I'm so happy to have another cardiologist kind of with me in this, contrarian viewpoint, if you will. Although, like you said, the other cardiologists actually know the truth, but they practice differently. But let me, myself, I'm cardiologist, Dr. Jack Wolfson, founder of Natural Heart Doctor, and I got my colleague here, Dr. Andrew Rudin, with me as well. And both of us are available for virtual consultations, et cetera. And, we're really just trying to help people from being, wrong. Like the last person, that we're talking about here, this is a person with no symptoms, no problems whatsoever. They wind up reading a book. They get a CT scan. They didn't need the radiation. Then they get a stress test with radiation from nuclear medicine that they didn't need. And then they get an angiogram. So now 3 different radiation episodes, plus a drug-eluting stent and the pharmaceuticals. We're here to right the wrong and waken people up. And this is, this is a typical example. Just pulled this, again, where we can see the patient here. On the left, this is a before, and the right is the after shot, and this is them getting a stent, for that blockage. But Andy, are you telling me that, and this is the quote unquote widowmaker, another opportunity where the cardiologist comes in. I know you love this term, the widowmaker. So we saved your spouse from being a widow because we saved your life here, which is so untrue. And let's just say, on the left, this is a person who had a CT scan. CT scan showed coronary artery calcification. Maybe a CT angiogram or a Clearly scan showed that there was a high amount of stenosis in the proximal LAD where the arrow is. And in the asymptomatic person, have we done anything for this person, Dr. Rudin?
Well, we have done something, Jack, and that you kind of alluded to it, and that is the CT itself is about 12 millisieverts, so about 500 chest x-rays approximately in radiation. A nuclear stress test similar, another 500 chest x-rays. And then the cath is more variable depending on their fluoroscopy rate, depending on how much cine they're using. But let's conservatively say another 500 chest x-rays. So this patient maybe had 1,500 chest x-rays, just a guess, worth of radiation from this workup of an asymptomatic lesion. And that's not benign, Jack. About 3,000 or 4,000 a year cancers in America, at least, are from CT alone, let alone other radiologic modalities like cath and nuclear scan, et cetera. So we're looking at a significant issue that very few people are talking about.
It reminds me of a study of a person who is a longstanding family friend, and in his late 40s, he had bypass surgery, and then every year he would get a nuclear stress test, and he wound up having another blockage, another stenosis in his lima, his mammary graft that was used in the bypass surgery that was stented. He winds up getting prostate cancer. He has radiation for the prostate. And then at the age of 71, he gets diagnosed with acute myelogenous leukemia. And everybody in the family kind of came to me and they say, how'd this happen to our father? How'd this happen to my husband? And just all this massive amounts of radiation exposure undoubtedly is a factor that led to this man's leukemia. And then he was dead very quickly.
Yeah, terrible story, Jack, but I think that highlights the difference between our practice at Natural Heart Doctor and conventional medicine is our time frames are longer. We look at the person as a human, and we look at throughout their whole lifespan. What's going to happen to the gut biome after antibiotics? Not, in 6 months, but what's going to happen in 5 years when now they have more inflammation and it's worsening their rheumatoid arthritis. Now you have radiation and you get cancer 5 years later. That's not going to be in the study. It's not going to be in the ischemia trial. It's not going to be in the courage trial. It's not going to be in the orbiter trial. Those patients end up getting cancer. They end up getting radiation damage to the heart, radiation damage to the lungs. None of this stuff's in any trial because the time frame is 5 years later, 10 years later, 20 years later.
This is the information you're going to get, people, when you work with Dr. Rudin, when you work with Dr. Latanzo, when you work with Dr. Rainier or any of the physicians and even coaches at Natural Heart Doctor. This is the information you're going to get, because what we're all about is how to prevent, treat, and reverse cardiovascular disease naturally. And Andy, in the case of an acute myocardial infarction, we're not saying don't go to the emergency room, get an angiogram, angioplasty stent, correct? There is a time and a place for that procedure.
Yeah, absolutely, Jack. That's a great point. This particular case isn't even close to having an indication for a stress test or cath because there's no symptoms. The reason to think about stents and invasive workup would be for symptoms. But certainly if you come with an acute heart attack where the artery is completely blocked, it's a different situation because now you have myocardium at risk and minutes are myocardium. So opening an occluded heart artery, that's an emergency, and I'm all for cath and invasive procedures at that stage.
So now what we're going to do is we're going to get into 2007. So I talk about this in my book, which was published in 2015. But this goes back. This is New England Journal of Medicine. This is the Courage trial by William Bowden or Bodden, Robert O'Rourke. I mean, these are huge. David Marin, huge players. Bernard Chapman. I mean, you know all these names as well. Leslie Shaw. These are huge in this space. And this trial, 2007, where they're looking at their medical therapy, what they call optimal medical therapy, and then half the group got an intervention and half the group did not get the intervention. And the findings, I'll let you maybe summarize these, Andy.
Yeah, I mean, these were patients with stable angina. They weren't asymptomatic patients like in our case study, but they were followed for up to 7 years with optimal medical therapy or optimal medical therapy plus cath and PCI, cath and stent. And up to 7 years later, there was no difference in heart attacks. There was no difference in mortality. So when the 80-something% of patients that I alluded to in the earlier trial were in the cath lab pre-op area, almost all of them felt that that cath jack was going to improve their survival, prevent heart attack. And as we see from the COURAGE trial, the largest trial to date at that time, it was very disappointing to interventional cardiologists everywhere. This trial was supposed to finally show a benefit of angioplasty. We've been doing angioplasties at this time for decades, and the trial fell flat on its face, unfortunately. Well, fortunate, unfortunately. The data is what the data is.
Yeah, I would agree. Unfortunately for all the patients who didn't need the procedure and suffered from it, but nonetheless, and this group was actually higher risk than the first case study that we just talked about, where there was no symptoms. These people either had symptoms or they had highly abnormal stress tests, which we don't know the results of the stress test that the person had. But even with a moderate to severe ischemia or area at risk on a stress test, an intervention did not help even after 7 years of follow-up in the COURAGE trial.
Yeah. And one other thing, Jack, is that's important, I think, that, me and you were talking about this earlier. If you look at all these trials, and, we're going to summarize 9 trials, I think, later, the big ones, this trial, the COURAGE trial, and then the ischemia trial, the endpoints they're looking at heart attack, death, cardiovascular death, but the things they're not looking at are a big issue, Jack. And there's small endpoints that impact patient, quality of life that they don't look at.
Yep.
For instance, up to, post bypass, up to 40% of patients have lesions on the brain by MRI, diffusion weighting. By cath and angioplasty, up to 15% of patients have new lesions in their brain. And, sometimes it's hard to find by, normal neurologic testing, did they have a stroke? But it's certainly a stroke on MRI.
Yeah. Yeah. I mean, I think a lot of those people, bypass, who went for bypass surgery, their brains are just never the same. It certainly didn't improve people's, health by having bypass surgery as far as their brain is concerned.
Yeah, absolutely. I was taught as a beginning intern by one of my mentors that nobody ever came off the pump any smarter. And I used that. And unfortunately, I didn't make the leap to go from bypass to angioplasty. For bypass, it's obvious. You go on cardiopulmonary bypass, you're not perfusing the brain, the frontal lobe's being showered with small emboli. So it's more obvious in bypass to note that you're going to have some soft neurologic damage. But from cath and angioplasty, the biggest worry of the cath is when you're going around that aortic arch, Jack, and that aortic arch sends vessels up to the brain. And you don't just have atherosclerosis in your heart arteries. You have it in the aortic arch too. And we shower some of that emboli up to the brain, undoubtedly every cath, whether or not you do an angioplasty or not, and whether or not you measure it by an acute stroke or do an MRI, there's some damage to the brain.
I mean, isn't it a scary proposition when you think about that? If you think it was you laying there on the table or me or any family member, and you think about how there is that plaque that's going on all around the body in that aortic arch that is going to supply the carotid arteries, the vertebral arteries to the brainstem, and that's just kicking off plaque or emboli. I think that doctors 100 years from now are really going to look back and have the commentary that we were very, very, very barbaric in our thinking and what was going on. And some of it, again, not to go too conspiratorial, it is so financially driven, all these different things at play here.
Think of how popular you would be, Jack, if you wanted to study neurocognitive effects after cath, neurocognitive effects after angioplasty with MRI, now that we have good tools. I mean, you would be, pretty unpopular in your department. I mean, cath and
you would definitely
that pays for the whole hospital, Jack.
You would definitely not have a lot of friends, and you probably wouldn't have a lot of job. You wouldn't have a job. You'd find a way to be worked out of a job. So how do we ever really learn the truth?
Yeah.
Well, I mean, and then how about this? I mean, how about kudos to New England Journal of Medicine for even publishing this stuff? I mean, these journals are bought and owned by, Abbott and Medtronic and Boston Scientific. I mean, the fact that the negative data ever sees the light of day, it does amaze me.
Absolutely.
It does amaze me.
Yeah, most of the trials are owned. The data is owned by the pharmaceutical company or the sponsor. Absolutely.
Yeah. I use this example, pretty often as far as, I'm the CEO of a pharmaceutical company, and my director of, research, comes in is, oh, okay, well, listen, Mr. CEO, it turns out actually the drug, not only did it not work, it actually killed more people. So just thought, you need to know. So what does the CEO say? Okay, well, you director of research, you're fired. And if you ever say a word about this, something, you'll never work again in this field, or something may happen to your family. I mean, we're talking about billions of drugs. I mean, right? I mean, Andy, is that so not possible? I mean, is that really so conspiratorial to say that is a possible conversation and maybe a little bit nuanced? But ultimately, I think that there's billions of dollars at risk here, and if you go against, it's not a good career move to go against.
No, it's definitely not.
The grain.
Listen, doctors chose the field because they're not gamblers, Jack. These are safe people that are conservative. They're family people. They want to, protect their nest egg, retire, and have a nice life. And they're not. These aren't people that want to go against the grain and challenge authority, challenge the money. These aren't risky people.
Yeah. Okay, so that was the 2007 study, right? So people would say, yeah, well, that was, data from almost 20 years ago. Things have advanced since then. So the beautiful thing is
that's what people that defend that trial, they say that there was only coated stents, chemotherapy coated stent toward the end of the trial. But then we have the ischemia trial, which we're going to talk about next.
All right, so we got it here. So this is April 9th, 2020. So we are coming up from 5, years. Again, New England Journal of Medicine, a lot of the same authors too, which I thought was pretty cool. David Marin heading up with here, Judith Hockman. I mean, these are huge people, very well known in the interventional cardiology space. So this was called the ischemia trial, and everyone, this is all available for you to go read online. We don't have the links here. We'll publish this as a YouTube video, and we can send some links to this. You're welcome if you want to read the original research. But these are very high profile studies. So here's our conclusion on this one. Among patients with stable coronary artery disease and moderate or severe ischemia, again, these are people who may or may not have had symptoms, but they have evidence of coronary artery disease, and they've got these abnormal stress tests. This is just like the person that we're talking about. We did not find evidence that an initial invasive strategy as compared to initial conservative strategy reduced the risk of ischemic cardiovascular events or death of any cause. So I guess one thing I would say here, Andy, is that this bravado of the doctors of we saved your life, we prevented a heart attack, those comments are simply not true.
Not true. And Jack, what's surprising is that there's some cognitive dissonance, I guess, some disconnect between the doctors will answer that question right, I'm pretty sure, on a multiple choice test, that we do cath for symptoms for angina, and that it didn't save lives, it didn't improve survival, it didn't prevent heart attack. They know that answer that'd be a very simple question on the cardiology boards, Jack. But for some reason, they're not conveying that to the patient. It's not on your informed consent form. Everyone's made a big deal out of informed consent over the last, few decades of medicine. But is there informed consent here, Jack? Does the patient know? You go to the average cath lab waiting room now. Do those patients know there's no survival benefit, there's no prevention of MI benefit from doing this procedure?
Yeah, I love that. Can you imagine that if you had to sign a document where it said in big and bold and the nurse had to read it off to you? The procedure that you're about to have has not been proven to prevent heart attack or prevent loss of life, to improve mortality, to increase longevity. Can you imagine if someone had to sign that document and they would look at that and they would say, and this is only proven to help symptoms, and the person's laying there in the bed and they're like, wait a second, I don't even have symptoms.
Forget about bold print, even the fine print, it's not there. I mean, there's no mention whatsoever of that statement. And the cardiologists know, but does the regular referring like internists know? I don't know. I'm not sure their knowledge. I'm not putting anybody down, but this just has not been publicized, Jack. This is kind of unspoken, facts that we've known about now for 40 years. It's an inconvenient truth.
Well, I think, and that's what's cool about how you and I reconnected, over the years, is that we both kind of came to the same realization. Again, there's a time and a place for modern cardiology, yada yada. That's okay. But it's like we sit here and we kind of like laugh about this because it's really just so egregious. It's such a violation of people's rights. And again, that's our intention here, is to really wake people up and get people informed. And I like to say this too, because I know you've seen a lot of this, Andy. How many times over the years somebody gets admitted on a Friday afternoon? Okay. And we're going to let them cool off over the weekend. And then we're going to do something to them on Monday. And I tell people that if it's not an emergency, then you need to make sure that that you request to speak, with one of us over at Natural Heart Doctor, get that second opinion, because if it's not an emergency and they want to hold off for a few days, well, they can certainly hold off a little bit longer for you to have a conversation with somebody else to get a different opinion.
That's another talk about those people, Jack, with that probably be unstable angina, non-ST elevation MI. If it's not emergent, it's not emergent, period. And another few days, weeks, month to discuss the options, to think about a plan, is always a reasonable option.
Well, I mean, but this could also be a person, I guess, that, I think, obviously we're doing weekend stress tests. We've been doing that for a long time. That's not a big deal. Scenario of, again, like they came in on a Friday, say they had a stress test on a Saturday, right? And now the stress test comes back abnormal and they're automatically setting them up for a procedure, an angiogram. Like, hold on. Oh, yeah, hold on. Let's talk about that. If it's an emergency, you pretty much, you got to go with what they're saying and you got to pray for the best. But when you've got time to sit back and think about it, let's have a conversation. So that's the 2020 data. And then you sent this over to me as well, this meta-analysis in 2022, where they looked at 9 trials where they're looking at medical therapy. And I do want to say this too, is that these are people that are not under the care of a natural cardiologist, right? These are people that are getting optimal medical therapy. So they're getting blasted with statin drugs, typically aspirin, historically ACE inhibitors, beta blockers. So they may be on many different pharmaceuticals as quote unquote long-acting nitrates as optimal medical therapy. But our intention over here is to say we're going to do even better than that, because we're going to use natural treatment strategies for these people. But tell us about the 2022, trial, what they were, what these authors were looking at here. We posted this in here, the summary of cardiac mortality, heart attack. Maybe talk us through this a little bit, Andy.
So, I think what you're looking at, we gave angioplasty or invasive strategy a really good shot in these 9 trials. If you look at all 9 combined, there's no benefit for prevention of MI. There's no benefit for mortality, for survival of getting a cath and a stent. So you don't feel pressured. I guess the take-home message here as a patient, don't feel pressured. That cath and angioplasty is not going to save your life. It's for symptoms, and how good it works for symptoms is another topic, Jack. Probably not very good. I mean, we looked at, there was a big trial called Orbita and Orbita 2, where they did a sham angioplasty on patients. They actually did a cath and did a sham angioplasty, where half the group didn't get angioplasty, half the group did. And then they followed treadmill and angina scores, up to a year later. And what they found was that the angioplasty really didn't have much of an effect, at least compared to compared to optimal medical management. There was no benefit from the angioplasty compared to no medical management in the Orbita 2 trial that was later done, because the Orbita 1 trial was kind of an embarrassment, that angioplasty versus stent had no benefit at all. People that just underwent sham angioplasty felt better. But in Orbita 2, where they took all meds away, yeah, those patients had better treadmill time, but again, no impact on heart attack or survival.
That is absolutely astounding. I mean, this here, like summary of cardiovascular mortality. I don't want to get too statistical with people, but you can see that relative risk for overall cardiovascular mortality, 22% higher in the treatment group that got angioplasty, stent, and/or bypass surgery. So our intention here is to say, okay, we're not saving any lives here. We're not preventing any heart attacks with this methodology. And here the authors conclude our results revealed no statistically significant difference between MT medical therapy and PCI in terms of studied primary outcomes. The findings also highlighted that there is no statistically significant difference between medical therapy and bypass in terms of cardiac mortality.
Yeah. So that's amazing thing is even when you take the bypass patients into play, that still medical therapy was just as good.
Yeah. You alluded to this earlier too, what are the risks? And we talked about stroke risk from bypass surgery and from interventions. Again, I mean, you're putting these silicone catheters, and you're just they're knocking into, it really is this mechanical abrasion that's happening in that particular area. Talk about though, even things, I mean, obviously, the risk of bypass surgery, all that go along with that. And then long-term, morbidity related to that. I mean, whether it's a sternotomy or any other kind of procedure there. Talk about also the local complications. I mean, whether it's the radial artery, I mean, how about the femoral artery? What happens there, what we do?
Yeah. So it's interesting. If you look at the Orbita 2 study, where they did sham angioplasty on half of the people, there was 3 major bleeding episodes out of about 300 in the sham group and 2 in the group that got angioplasty. So even if you have a regular cath, there could be major bleeding, Jack. But forget about the major bleeding. That was largely femoral approach. So a lot of docs now, to reduce the major bleeding because they've known it's a problem, go to the radial artery approach. But to me personally, if I was ever going to have an angiogram, I think I'd rather have it in the femoral artery and take my risk with bleeding, because what's going to happen to my hand? What's going to happen to my wrist from damaging the radial artery? The radial artery provides a huge percent of the blood supply to your hand, Jack, and up to 10% of the time it gets completely occluded after cath. It gets showered, it gets ischemia, shower with emboli downstream, gets ischemia from doing the radial artery cath. People are attuned to that. They're trying to do less compressive holds after the cath, but nonetheless, there's damage to your hand, and almost everyone goes in the right side. It's the predominant side, and most of us are right-handed.
Yeah, no, that's a good point. I think maybe to get a little bit nuanced here, maybe in the obese person to go radial, and then in the average person go femoral. Maybe that would be a thing. I mean, you and I have done a ton.
Yeah, you can't even an obese patient going in the groin. It's the anatomy is distorted that you can't even press the artery over the femoral head. So the bleeding risks are, you know, extensive in an obese patient. That's a good point, Jack.
Well, I would say like that was always the scariest thing. And again, usually in the cath lab, of course, you're working with other people who are used to dealing with that. But us, you know, as kind of like young cardiologists, and you got this femoral artery that is buried, you know, down deep, and especially in the obese person. And that's all that we had, you know, during in our training, right? I mean, you know, radial stuff came, you know, really at the end of cardiology fellowship, you know, for both of us when people were doing it. And man, that femoral artery deep down there, it was a scary proposition. A lot of people bled, and some people unfortunately bled to death.
Yeah, absolutely.
Yeah.
Major bleeding is definitely a concern, but and listen, there's more than that, Jack. There's being labeled a patient, you know, being stuck now in the medical pharmaceutical kind of machine. And the other issue is depression. People don't talk about it, but there's a huge incidence of patients, if you look at them when they get to cardiac rehab, of depression. And, you know, some of it's attributable to different meds. Some of it's attributable to the fact that now you're a heart patient, now you're damaged. But some of it's certainly from the central nervous system, that you took emboli to the brain. And, you know, people haven't really counted that. There's a lot of negatives that come with doing an invasive procedure. You should have a very good reason.
Yeah, I mean, right. And for the asymptomatic, and how, you know, I remember speaking to this guy who I did a consult on, and he was from London, and he's in his early 50s, and he goes for a CT scan that leads to a stress test that leads to two stents being placed and on pharmaceuticals, and yet the guy never had any symptoms. And you're right. What are the psychological consequences of that? It's really it's quantifiable, but on a massive scale, and the long-term impact. So we're kind of summarizing here right now. Stents and bypass are for symptoms. No heart attacks and strokes are prevented. No lives are saved. Of course, you got all the risks. You got all the pharmaceuticals. You get the less quality of life, more morbidity. And of course, they're not addressing real health.
Well,
So
absolutely. A patient takes Lipitor and now they eat a bad diet. They have a stent. They think, well, I don't have to exercise. I don't have to watch my diet. I'm protected. My artery's open. The hero doc saved me. So probably that's the real crime, the real criticism of meds, conventional meds and procedures, is that it takes away the responsibility from the patient, takes their ownership in their care out of their hands off.
yeah, most certainly. All right. So again, if you are watching this video and you want to work with the best natural heart doctors in the world, that's what we do over here at Natural Heart Doctor. Myself, Dr. Lauren Latanza, Dr. Andrew Rudin here, Dr. Tanya Rainier, Dr. Keith Smeagol, and a team of health coaches around the country. We're here to help people to give that second opinion. And really all you have to do, you go to the appointments tab on the Natural Heart Doctor page. If you like what Dr. Rudin said, I would highly encourage you to do a consultation with Dr. Rudin, or again, if you prefer Dr. Latanza or anybody else, you're going to get great information. And again, my friend Andy, for a long time, and both of us as 20+ year cardiologists, as crazy as that is, between us, we got probably close to 50 years on the job, which is absolutely insane since we met when we were 18. So in any case, I want to thank you again for being here and being with us at Natural Heart Doctor. And for everyone here, again, drop some comments, send some emails. We are here to help. Dr. Rudin and I both left conventional medicine. We both left highly lucrative, safe positions as mainstream cardiologists to do the right thing over here at Natural Heart Doctor. So we're happy to help you going forward. So Dr. Rudin, Dr. Jack Wolfson, thank you again for this presentation. We'll see you next time.